Well, it's ASH 2014, and we're in San Francisco. It's December 7th, 2014, and this is David Wallace with PV Reporter, and we're here with Dr. Lee Greenberger, who's the Chief Scientific Officer of Leukemia and Lymphoma Society. Lee, one of the first things I wanted to ask you about is LLS has a $1.7 million initiative with Janssen Research and Development, which is a division of Johnson & Johnson, to halt the progression of myeloid blood cancers, including NPNs and MDS. This seems to be an area that's getting a lot more attention lately. Can you give us more details on the Transforming Cure initiatives and some of the goals of the program?
So the Transforming Cures initiative is designed to identify mechanisms and perhaps therapeutics that would be useful to control initiating disease to full-blown disease. Because obviously once the disease is full-blown, it's much harder to treat. So there's definitely a movement afoot through this grant, and we have grants as well that we work with Dana-Farber to try to understand what are the initiating events that control early disease. What are the molecular events? That's part of the solution to blocking full-blown disease. And then the other thing we need to do is to identify therapeutics that could be used that would be both effective and safe. And don't forget that because this is early stage disease, it's not like, some of the therapeutics in oncology are harsh and have some harsh side effects. There's no need to put a patient through that if they have early stage disease. Nevertheless, for many of the blood cancers, and NPN and MDS are those type, where the patient comes in and said, you've got something trending in the wrong direction towards AML, we're going to do a watch and wait in some cases. Not a very satisfying solution. So we think we can definitely do better. I could tell you that, of course, for MPNs, we now know there are JAK mutations. There's this thing called CALR mutations that we're seeing. The CALR mutations, the role of CALR is really not well understood. We need to do a lot more work to understand that. The JAK mutations, at least we have one drug, ruxolitinib, on the market that can be used to control the disease. And so we need to understand and develop therapeutics that hit JAK2 and how to get around JAK2 resistance. But there's a long way to go with other mechanistic studies to understand how these events occur and they progress.
Okay. All right. Are you looking to partner with other pharmaceutical companies and organizations in the NPN space?
So, of course, we do have a partnership with the NPNRF, the Chicago-based foundation, and we are very proud to work with them, and we've funded numerous grants. In fact, we just did a round of funding of numerous grants with them as a joint venture. So what we do is we put in money together. We review these grants together. We evaluate them and we decide what we're going to fund together. So it's quite an interesting collaboration. What it does is it expands the ability of both organizations to do research. And also I might add that we're able to also bring in world-class experts to evaluate these grants and in some cases get the grants and run the programs.
That's excellent. And for me as a PV patient, I'm excited about all these new initiatives. So I try to stay on top of that for our readers. Let me ask you this, Lee. One of the things that I came across in the release was that the grants are going to focus on molecular drivers that cause progression to leukemia and development of new treatment strategies. And kind of may have answered this, but would you expect to uncover new mutations along the way that may play a role in treating the disease or halting?
So there's a lot we don't understand about early stage disease. In fact, if you look at, and this is some of the work that the Leukemia and Lymphoma Society funded, recently. There's a couple of articles that came out in the New England Journal of Medicine talking about what mutations do you see normally out there in so-called normal patients. And with the surprising finding of two big studies looking at about 15,000 patients from distinct categories, they didn't have blood cancer. What you find is that there were mutations in those patients, and they occurred as they got older. So for example, by the time you're 70, 10% of these patients have the mutation already. They don't have the full-blown disease.
Right.
Some of them will progress on to full-blown disease. So they were mutations that occur frequently in hematologic malignancies. But they basically, what they appear to do is sort of set the stage, that they make these so-called stem cells, and they mutate them. There's one mutation in a gene. Doesn't cause the disease yet.
Right.
And then when you get a second event, then you get the full-blown disease. So understanding early on, those are they look like molecular drivers. They're early stage setting mutations that will lead to disease. So those are the type of things we need to understand, and we have a long ways to go to understand how all these work. It's interesting that the genes that came out of these studies all seem to control what's called epigenetics. And so, if you don't know what epigenetics is, it's basically, consider that your DNA is sort of a railroad track, and it's got all these bases, right?
Okay.
So you can have a change in a base. That's a mutation in one of the railroad tracks, and the train goes off the tracks.
Right.
It turns out that, consider a railroad track with a lot of stoplights, green lights, red lights down the track. That's the epigenetic changes, basically annotating the track, whether a gene should be read out or not, sort of the stop and go signals. Those are the epigenetic changes I'm talking about. Those are the genes that were mutated early on, before these patients actually had full-blown disease. So what it's telling us is that there are mutations in genes that can lead to disease. They change the epigenetic status. There's sort of the stop and go of reading out proteins that we don't understand well, but there's a big clue that we should go after epigenetic controllers. And we do have some drugs on the market and some drugs proceeding forward to basically turn these green lights to red lights and red lights to green lights, and understand that turning off a gene and turning on a gene could be equally important in terms of regulating the whole array of ultimately which genes go on and off. So you may want an inhibitor, maybe a stoplight, maybe you want to actually turn on the stoplight.
Okay.
Or maybe you actually want to turn off the stoplight in some cases of some other genes.
Okay,
Yeah.
and it's interesting you mentioned about all the different genes. I had spoken with Dr. Stone earlier at Dana-Farber about the 95 gene heme panel that they had developed.
Right.
And it seems to me there's so many latent genes that we all carry. We don't really know what the triggering event is that sets those off, right?
Right. And so that's some of the early work that's just come out of it, actually at Dana-Farber and Harvard, where they basically looked at these early events and to get an indication who might progress. But actually, it's a sort of a probability, saying you have these mutations, you might progress or you may not. Only 4% of these people who have mutations went on for blood cancers, but there's a high prevalence towards proceeding towards blood cancers.
Yes.
Right, as opposed to some other cancer type. It's
Yes.
telling you that those are important players. I know that there's a 93 panel gene or 95 panel gene at Harvard. There is another Foundation Medicine, for example, has a 400 gene panel. There is a gene panel at MD Anderson. So everybody seems to have their own mix.
Right.
And to try to determine what is important, do it in a timely way, and control the cost. Right?
Right.
Because you can do all these, you can test every single gene and make the cost go sky high, but you're like, which are the mutations that are actionable? How do you know, if you get a change in a gene, do you act on it? Well, maybe it's a driver, maybe it's just a passenger. It just kind of occurred and it's just hanging. It was important, and it led to a change in the status of a cell it's no longer needed.
Right.
But it got it to that ultimately got it to a mutational state, no longer needed. So if you take it out, nothing happens.
Okay.
Or it's really a driver.
Right.
That it's really actually promoting the cancer. Stopping that will make the cancer go away.
Okay. And one of the things that I've seen just from the patient level is these gene panel studies that are out there. I was talking to my local hematologist based in Charlotte, and I mentioned it to him, and he said, well, we're working on our own. And what kind of struck me was if these gene panel studies are out there, it
Right.
seems like they're kind of isolated into their own institution. Or how do we get that down to the local level without my local treating physician having to spend 2 or 3 years to develop something similar?
Right. So, to the Leukemia Lymphoma Society, who sort of is agnostic to who's developing it, to us it seems like these things should be coordinated.
Yes.
So there's a variety of ways to do that. One of the things we've actually thought about is actually providing grant support to collect this data into a database. So instead of having a 95 gene panel or a 400 gene panel with 200 patients here, 200 patients here, take the power of combining the whole analysis. That's number one. Number two is in terms of getting the information out to the community doctor. So some community doctors might set this up on their own, or they may go out to a company that ultimately does this.
Yep.
Actually, not a bad solution if it's a sort of Foundation Medicine is basically a for-profit company that they will do this. So anybody in the country could send a sample to them, and they will do this analysis.
Okay.
So then what happens? You get the information back, and even the most sophisticated doctors who actually have created some of these panels, let's say it's Sloan Kettering, look at it and go like, okay, there's probabilities that we might go with this pathway or that pathway. And we see this mutated, that mutated. That's actually a complex decision. Now put it in the hand of a community medicine doc and go like, what do you do with all this stuff?
Right.
And so there's got to be an ability of these community physicians to get access to the data, and then there has to be some sort of educational method so they can actually act on the data.
It's an interpretation issue, isn't it?
Absolutely. It's an interpretation, and it's really an interpretation in the truest sense that it's a probability that a patient who has a mutation X is going to respond. So maybe it's not a driving mutation. Maybe the drugs to work against that are not very good and really won't work well. I should go with a different drug.
Right.
Maybe I should just go with the conventional therapy and then bring this mutational analysis, or should I go after the mutant ones right up front? And so there's a lot of judgment calls, and some of these companies can provide a list of, well, there's a probability that going after this might be it's better to go one way versus another. It's a judgment call.
Okay.
And it's a little daunting for some physicians to make a call going like, well, which one do I choose? I don't know how that is all going to ultimately come out. It's clearly education out there across the country. But we recognize that not everybody has access to the most sophisticated medicine, which might be happening at the major cancer centers, who actually might have teams of doctors who analyze this stuff day in, day out.
Right.
So somewhere along the line, that we've got to make that transition, particularly for early stage disease folks who may not, may go to their community physician and say, I think I can treat this. This is not a case where you have to go into a major cancer center and get a second opinion by the most qualified people, because it might be just say, we should watch and wait.
Right.
Or there are drugs to treat that I think I can control this, and it's not something we should act on immediately. On the other hand, there could be data in that gene set going like, hey, wait a minute. This is a prognosis. It looks like this is going to be difficult to treat. We really need to get on top of this with a more sophisticated medicine.
Gotcha.
So the danger of providing the data, if on one hand, if you don't act on it, you may have missed an important clue you should have acted on it. On the other hand, you provide the stuff and you go and you act on it when you really shouldn't have acted on it. You should just wait.
Right.
So that's a tough call. Some of it is predicated, particularly for early stage disease, to have therapeutics that are effective and safe. So you can imagine you have a fever, take aspirin.
Sure.
That's going to be the side effects will be very mild and it's likely to be effective. If we had drugs to treat early stage disease like MPN and NDS, we could do that. We typically don't.
Yeah.
Although there are some clues that come out of this very large database that I talked about that would suggest that maybe there are some therapies that we need to look at that we haven't even considered, like metabolism drugs. Like for example, drugs that control lipid metabolism, like a statin, that we might even should have even considered, where we never would have even considered because there's no data to indicate that's important.
Oh yeah, and last night I saw one of the poster sessions on PV, and they were talking about Humira being used. So I think there are a lot of different agents that haven't even been considered that are now being looked at.
Right. Right. Even, and I think what's come out of this conference is that the immune system plays a very important role in meeting hematological malignancies. In many cases, the tumors will basically turn off the immune system. So if you activate it by either getting the so-called chimeric antigen receptor therapy and basically have these T cells recognize the tumor cell and kill it, or you take the brakes off, you remove the brakes and activate the immune system. That's what these other PD-1s, what this whole PD-1 story is about.
Right.
That could be a very important component, but what they're telling us through therapeutics now is that the immune system basically has surveillance of what's going out there in the blood cancer space. And the tumors have the ability to basically just mask it, that the immune system doesn't recognize that something's gone wrong. So that's a very interesting avenue drugs that activate the immune system that might be useful, that don't do it in a way that has a lot of safety issues, that maybe to control early disease would be important. So could you imagine if there was a vaccine, for example, which is basically an immune activator to early stage disease, if we had something like that, to tell the immune system, wake up, that something is wrong, and here's, this is what it looks like.
Sure.
To train the immune system, and so it can find it when it's there and get rid of it.
And maybe I'm hopeful that we're just a few years away, perhaps, from that, but I know there's no timeline.
Right.
Obviously.
I think the exciting thing is, the progress has been so rapid, and in the blood cancer space, so productive, that we're pretty encouraged that we're going to see it sooner than later.
Okay.
Yeah. Don't forget, the society's been around for 60 years, right?
Yes.
We've been funding research for a long time, $1 billion worth of funding, and so look how long it took to get combination therapy, which has been highly effective for leukemia. It took decades to figure that out.
Yes.
And we knew, for example, that the immune system can actually get rid of disease. We knew that if you take an allogeneic transplant, so it's coming from a different patient into another patient, it has the ability to get rid of the cancer. And it does that by using the immune system. So we knew that existed. We've done it for decades.
Right.
We just didn't have the systems and the therapeutics to figure out how to activate it and understand the immune system. We do now, and perhaps those will be useful in early stage diseases like MPN and MPN and MDS.
Okay.
Yeah.
Excellent.
Yeah.
Well,
I should add another comment.
that?
I think also the genetics are telling us that in the case of MPN, where you have JAK mutations and CALR mutations, these are molecularly different diseases. And so instead of trying to approach it as going like, I need a drug that's going to control MPN, I said, no, I need a drug that controls this mutation, that mutation, relevant to different types of NPNs. So you sort of begin to take the whole pie and slice it up. That's actually a challenge from the pharmaceutical perspective, because now you're saying, well, I'm not treating all patients. I'm treating patients that only have a BCR, a translocation of BCR-ABL, that's CML, right?
Right.
And then you go into ALL and you go, hey, wait a minute, those patients have a mutation as well in BCR-ABL. I should treat with the same drug. So it's that understanding of, don't treat all the tumors the same. Treat it with what the molecular defect is, whether it be JAK2 or you imagine something that would overcome CALR mutations. And that's the way you should be treating it. That's ultimately the way it's probably going to go.
Okay, so we're really talking about targeted therapies
Yeah.
towards the gene mutation that's there, and that's kind
Right
of where we're
drug,
heading.
the right drug for the right patient with the right molecular characteristics. That's ultimately where it needs to go.
Okay.
And it'll save patients a lot of hassles of going through therapy that's not effective, and it'll get it to the patients who do need it and have an effect.
Okay.
Yeah.
Excellent. I just want to say from a patient and reporter perspective that I'm excited to see LLS be involved in the NPN and MDS arena, and I really appreciate everything you guys do, and I appreciate you meeting with me today, Dr. Greenberger.
Yeah, well, we're happy to do so, and we're excited. We think there's a bright future.
Excellent.
Yeah.
Thank you very much.
Okay. Thank you.